Now, when we look at encephalitis, which is mainly viral, but other organisms also can present with encephalitis, we can broadly classify encephalitis into sporadic, outbreak-related encephalitis, and the viral encephalitis you see in immunocompromised populations. So special populations like transplant recipients, HIV, cancer patients. Now, sporadic, we all know the most common cause is herpes simplex virus 1. And among the zoonotic viruses, rabies is important there especially in the developing countries. Of course, in many parts of the world, rabies has been eliminated, or geographically it's no more longer seen. And the virus we're discussing today, Chandipura virus, belongs to the same family of the Rhabdoviridae. Among the outbreaks of encephalitis caused by viruses, there are many and geographically restricted of them. J is in Asia and some parts of Asia, Southeast Asia, and even a small part of Australia is involved. Nipah virus, of course, we know is Bangladesh and India. Chandipura is what we're discussing now. And West Nile, very much in India. PCR-proven cases have been described with West Nile virus, meningitis, or encephalitis, or acute placid paralysis in our country. Otherwise, the other ones are not in India, St. Louis in the Americas, and Western equine, Eastern equine, Venezuelan equine encephalitis viruses in the Americas again. And of course, when there's an outbreak of dengue or chikungunya, a small in upsurges and outbreaks, you may see a few cases of dengue-related encephalitis also. With this introduction, let's go on to what is the terminology which we use now, that is acute encephalitic syndrome or AES. This is defined by the WHO as acute onset fever with altered sensorium, ranging from stupor to coma and new onset convulsions. Of course, there are criteria for this. Major criteria being neurological dysfunction manifesting with altered mental status for more than 24 hours without an alternate cause. Minor criteria are fever, new focal FNDs, CSF pleocytosis with more than 5 cells, renal imaging showing parenchymal changes, and EEG findings which are consistent with encephalitis. And based on these criteria, if you have a macrobiological evidence, that's considered as a definite AES. Otherwise, it's a probable confirmed or a possible AES. Now, if you look at the causes of AES, they are varied. Infectious causes as well as non-infectious causes. Among the infectious causes, you have in India, you have JE, Japanese encephalitis is one of the most important causes. Of course, many other pathogens, are there. And of course, rhabdoviruses, including rabies virus and Chandipura virus, come down there in the list. In the non-infectious causes, you have autoimmune, metabolic, one important, electrolyte imbalance, very important, and drug-induced as important causes. Of course, many others are there in the list. And when we talk of the Chandipura virus, if you look at the virus from where it belongs to the Rhabdoviridae family, the same family which has the rabies virus. Now, if you look at this table which I have made for especially for the residents, if you look at these viruses, rabies and the rabies-related viruses, including the ones which have been bold in black, the bold ones, Mokola, Juvenhae, European bat lyssavirus 1, 2, Australian bat lyssavirus, and Irkut virus. All these have caused encephalitis in humans. And Chandipura belongs to another genus, not the Lissa virus genus, which rabies and the other viruses belong, but to the vesiculoviruses, which again are neurotropic. So this whole family actually is neurotropic. What's important to understand is that rabies, of course, has a wide human animal range, but in many mammals, of course, we know that, and even rodents, smaller and mammals like rodents, are including monk, and of course the humans and non-human primates are important. Dogs, canines are, of course, very important as a source of the virus in our part of the world. But bats are an important reservoir and source in many other countries, European countries and the Americas, where dog population has been controlled with vaccination or with having separated from human living areas. Chandipura virus, on the other hand, we still don't know the reservoir. We just know the vector, but we don't know what's the exact reservoir for this virus. And the structure, if you look at the virus, it's the same bullet-shaped virions as for any rhabdovirus. If you look at the virion, it has a single-strand RNA, and associated with the RNA is the nuclear capsid-related proteins. You have the NP phosphoproteins, nucleoproteins, and the L large protein, and the RNA polymerase. And next is the matrix layer, which is just below the envelope, which contains a very important glycoprotein or G protein, which is an important brilliance factor for many neurotropic viruses of this family. At least in rabies, we know that this virus is this protein is important for neuroinvasiveness, and possibly this could be the same peplum or the protein in Chandipura virus also. Uh, the virus, being an RNA virus, replicates primarily in the cytoplasm. This is what is being shown here, nothing more than that. And as the virus transcription happens and translation happens, new virions bud out from the surface of the infected cells in in the CNS and other elsewhere. Now, if you look at the history of this virus, it was first actually detected from a patient with fever, no encephalitis, just fever from Chandipura village. And this was, they thought it was JE or some other related virus and or dengue virus. And they were looking for these common viruses when they found this on virus isolation. And this is way back in 1965 when only virus isolation was done and no PCR was available. There were no reliable serological assays at that time. And Chandipura is in Bhandara district now, in Nagpur division of Maharashtra. And sandfly is thought to be the major vector. Besides this, there were few cases in 1980 in MP, and then the major outbreaks happened in 2003, 4, and 5, and 6 in northern Andhra and central eastern Maharashtra, also in Gujarat in 2004, and then again in Andhra Pradesh. And after that, 2010, 11, 12, we had again smaller upsurges of this virus in Gujarat, Andhra, and Maharashtra, and some of these areas, similar in the same belt. And then, of course, now in Gujarat, which is the current ongoing outbreak. The important part is that encephalitis, or actually, I'll also discuss one more thing which I learned with this seminar, is that it's actually not a true encephalitis, it's actually encephalopathy. I'll come to that. Maybe Anvita will discuss that clinical part in detail later. But what is important is that the encephalopathy or encephalitis is mainly in children below 15, and the case fatality rate is high, 56 to 75%, about at 65% in most series. The vector is a sandfly. The old word sandflies, the phlebotomine sandflies are the main ones, but there is evidence of other sandflies of other genera and also possibly Aedes aegypti as a possible vector because the virus has been shown in these vectors, although they have not been proven as important vectors for transmission in nature. Now, this sandfly is a very minute, dark, light or dark brown insect, and it basically breeds near our houses, in our houses, in the crevices of and cracks of the buildings in the cement and bricks. And it's a very hairy, small insect with a very irritating, painful bite. It's a nocturnal pest and it doesn't fly long distances. So it just hops around near about the area where it's replicating, where it was born from the egg larva pupa stage, and it also and we know that this same vector transmits leishmaniasis. We all know that. It transmits two viruses: the Chandipura virus, which we are discussing today, and the sandfly fever virus, which is also known as papatassi fever and all. And of course, it also in South America it transmits some forms of Bartonellosis. Now, if you look at the outbreaks, the important outbreaks in India, the first outbreak was in 2003, and this paper, which is published by Rao et al. In Lancet, discussed from 329 suspected cases, cases which were clinically compatible with Chandipura encephalitis or Chandipura encephalopathy. 183 had died. That's a high case CFR, and the outbreak was proven by PCR, serology, and culture. And also in brain biopsy, they did immunofluorescence and fission detection of Chandipura virus proteins, NP, and other proteins by immunofluorescence, which was a direct evidence of the replicating antigens in the brain parenchyma. Another big paper which came in Journal of Medical Virology in 2008 was from isolates from Karimnagar and related areas of Telangana and Andhra Pradesh. And this, again, paper discussed about by PCR and by serology, the cases which were, the samples which were received at NIV Pune during that time. This paper basically compares if you look at here, the Chandipura 1965 strain with the other strains of Karimnagar of the previous outbreak I discussed about, and they found a there was not much variation in these strains, especially the nucleoprotein and the P genes were very conserved. And in fact, these are the genes which are used for PCR. I'll discuss that down the line. And then this paper from VP Bondre Group. Now, the person to contact in case we have a suspect cases of actually Dr. Vijay P. Bondre. He's head of the encephalitis group of NIV Pune. I'll share his number down the line and his email ID. I did talk to him in the morning today, and he has told us to start making the primers and probes for Chandipura in case we have an outbreak in Delhi and the surrounding regions. So we'll be in the process of making the primers and probes for this virus, and we have requested them to NIV Pune to give us a one positive sample control so that we can use and standardize our PCR at AIMS Delhi. So that will be down the line. Luckily, we don't have any suspected cases in northern India as of now. It's mainly in the same belt I discussed earlier. And now this paper, which came from the Dr. VP Bondre's group, shows about seroprevalence of this virus. Now, if you look at the table, it shows a very high seroprevalence actually in northern India. Uh, in Uttar Pradesh, it's almost 90%. In areas of Gujarat, Maharashtra, and Andhra Pradesh, it ranges from seroprevalence is IgG in the healthy population ranges from 70 to 85% in these areas, and Chennai 65%, Delhi 57%, and this is at that time. This is not current seroprevalence. This is in the 50s and 60s. I'm talking about that time when the virus was being studied, and there was not much known about the major outbreak had not happened that time. In Bengaluru in Karnataka, it's just 15% at that time. Sagar, again, Karnataka, 11%. It was very low in Kottayam in Kerala, just 6%. So this is about seroprevalence at that time, done by assays which were developed at that time, the 50s and 60s. And now, if you look at the virus isolation, this is in cell culture. From human sera, it has been isolated in 1965 from that febrile patient I discussed from Chandipura, the first from which the virus is named, Chandipura virus. Then from Raipur, now Chhattisgarh in Chhattisgarh. Then from Andhra Pradesh, Gujarat, and Maharashtra, the virus has been isolated from various outbreaks and upsurges in these times. And the virus has also been isolated from arthropods and mammals, mainly from various sandfly groups, mainly Phlebotomus and even the other one, Serenctomia, and also from hedgehogs in Africa, which is a small rodent. So the host range of this virus is now increasing from sandflies or arthropods to even smaller mammals, and it's now there's evidence of other mammals also being affected, being infected by this virus asymptomatically. This table summarizes the overall what I said, everything from the first detected case in India to till date, the virus has been found serologically and in animals from the Indian subcontinent, actually, Bhutan, Sri Lanka, Nepal, even from Nigeria, which I discussed earlier. And now coming to this outbreak, I think we have an esteemed speaker who will talk about hands-on experience in Gujarat. So there's no publication of this virus in on PubMed yet. So what I gathered was the news, the news items which I got from Reuters. A 2 day back update says that there are more than 100 cases with a 56% with a more than 50% mortality in children less than 15, and that's the usual trend of this virus. It usually infects children below 15. If you look at the clinical spectrum of this virus, it involves mainly children below 15. Adults are usually unaffected. It may have an asymptomatic subclinical infection. It may just present with acute fever or an influenza-like illness with myalgia, or it may present with an encephalitis AES picture, with encephalopathy actually being the correct term, if I may be allowed to use that term. The patients present with fever, altered sensorium, vomiting, headache, generalized convulsions, coma. Some patients succumb to this disease very fast, within 24 to 48 hours of its onset. Survivors, usually who survive, recover promptly, and there is no residual deficit or delayed sequelae in most of these patients who recover, the survivors. But the case fatality is high, quite high for an encephalitis virus, 56 to 75%. Other less common features include diarrhea, vesicular rash, etc. So this is one of the important slides I want to focus on, which shows that actually uh, this paper which came in 2000 12 discusses that actually none of these patients had a CSF finding. None of the autopsies, a few of whatever data of autopsies was available, did not show true evidence of encephalitis in the brain biopsies. So it's more an acute catastrophic brain event or an epidemic brain attack, actually, and not truly encephalitis. It more looks like a lack of supply limited to the drainage area of the middle cerebral artery with a spasm, a vasospasm, or an obstruction, which is transient due to a vasculitis probably, and not thromboembolism. So, and the lack of inflammatory lesions in pathology further support the notion that it's actually a vasculitic or acute brain even, and not a true encephalitis in its true sense. Diagnosis is by RT-PCR, which is the standard of care, or the standard test of choice. Mainly, the P gene has been used, but phosphoprotein gene, but the other genes have also been used. The samples are CSF, serum, and brain tissue if available. The virus can be cultivated. It's difficult to isolate in the first go, but once it's isolated, then it's difficult to maintain in the cell culture. Many cell lines, including VERO-E6, MDCK, and many other fibroblast-based cell lines and other continuous cell lines are good for this virus to grow. It also can be easily grown in laboratory mice and in hen's egg, showing that the host range of this virus, from avians to lower mammals to humans and other animals and humans, is much wider than we think. Serology IgM antibodies are available. New capture ELISA is preferred, but commercially, kits are not easily available for this virus, and IgG antibodies have been used for seroprevalence. Antigen detection in brain biopsy tissues by immunohistochemistry or IFA-based studies is available with reference centers like NIV Pune. For a conventionally for a virology lab, what we need is an RT-PCR, a reverse transcription PCR, and if possible, standardized kits for serology IgM, which are not easily commercially available as of now. I finished with my talk with this paper, which I am just trying to show that NIV Pune did standardized PCR from various genes, and they found the P gene to be very suitable. And we'll be using the same protocols which the NIV is using once we have the primers and probes ready in our lab. Treatment management is supportive care. There are no specific antivirals, although favipiravir was used in COVID in mice-based studies, but human studies are awaited with this drug in humans. There's no approved vaccine, although vaccine candidates have been developed, one by NIV Pune. Insecticides, the use of insecticides to protect ourselves from arthropods, especially sandflies, is the only possible prevention as of now. Thank you so much.
Thank you very much, Dr. Ashish, for an excellent talk. We'll take the questions at the end of the three talks.
Sure,
May
sir.
I now request Dr. Anivita to come on and give her talk? She can put our share slides. Sir, can you please unshare your slides, Dr. Ashish? And we'll ask Anivita to share her slides.
Thank you so much, sir. It is such an honor and privilege to be part of IAP and to have this opportunity here, not just to be a part of this webinar, but also to have the opportunity and the delight to hear Dr. Ashish, and his wonderful presentation reminds me of our residency days. It is amazing how we have all come together and we are trying to fight this current outbreak, and we're trying to learn better. I'm facing few errors. Just give me a minute.
Yeah, please go ahead.
Share the screen. Is my screen visible?
Yes, it is visible. You can put your...
Is it visible now?
Yes, ma'am. Yes.
So usually we read studied Chandipura virus as a short virology topic in our textbooks. But here with this webinar, I got an opportunity to thoroughly go through how this virus has evolved, and it has caused catastrophic events over the years. And currently we're facing one of the largest outbreaks of this virus. Unfortunately, many children are getting succumbed to this illness, and not much is being able to get done for that. So this was back in 1960s. This was considered as an orphan virus, as it was supposed to have low pathogenicity and it was causing infections mostly in domestic animals and hardly in men. However, over the years, one realized how catastrophic this virus can very much be. This lack of awareness and low clinical index of suspicion is why the diagnosis is delayed and missed. I'm sorry. And there is very high case fatality rates, so much so that in the current outbreak, we have over 50 cases which are confirmed in Gujarat, spreading out to Gujarat, Madhya Pradesh, Rajasthan, and even to Maharashtra, and almost nearly 150 cases reported. And this epidemic is the largest of the sorts in the last 2 decades. The country has not seen a worst outbreak, and it is gradually expanding. So, if we summarize what Dr. Ashish has already presented, we started off with the first outbreak in 2003 in Andhra Pradesh. At that time, it was called as the killer brain disease or the mystery disease, where typically a small kid between the age of 2 to 15 years would go to bed normally, eating well, looking well, but in the next morning, he would wake up ill. He would be in altered sensorium, he would be vomiting, he would be having a headache, and within a few hours, rapidly his condition would deteriorate. By the time the parents would be able to reach to the hospital, he would already be in a comatose and a decerebrate posturing state. This Andhra Pradesh outbreak in 2003 affected nearly 200 children, and within a span of 48 to 72 hours, many children succumbed to the illness. This outbreak investigation was largely incomplete, but they were able to establish isolation of Chandipura virus from the serum as well as from the PCR samples to confirm that this was a Chandipura outbreak. However, the evolution of vectors was ongoing, and it was later associated with the sandflies. So in early monsoon phase, where the sandfly replication is to the peak, is when these outbreaks were noticed to happen. Subsequently, 2003 to 2004, in the subsequent months, Central India saw various children succumbing to illness. Over 300 kids were affected around Andhra Pradesh, Maharashtra, and Gujarat. And the case fatality rates were as high as 75%. And in Gujarat, it exceeded even that. So this disease, because of its epidemiology of the vector, was localized over the lower income strata population where there was overcrowding, where the sandfly replication was there, and it affected younger kids from 2.5 months to 15 years old. Now, due to the monsoon season, where the vector activity is maximum, is where the spread of this disease was found to be the most. Now, in the initial years when this virus was actually being noticed, and rather these encephalitis were actually being attributable to Chandipura, there were other tropical illnesses that have been happening. And even in this current outbreak, multiple other tropical illnesses happen, which are an important differential diagnosis for any acute encephalitis syndrome, delaying the diagnosis of Chandipura virus. Even in the initial phase, the clinical presentations were similar to that of a heat stroke, where the kids would have high-grade fever and sudden altered sensorium. And many kids would die even before a diagnosis would be made. So the sudden worsening, altered sensorium, seizures, and some amount of diarrhea and vomiting were few features that were noticed in that outbreak. Subsequently, there were sporadic cases in various parts of Andhra Pradesh, now in the Telangana state and Maharashtra. And another major outbreak happened in 2007, where even few adult cases were reported. Unlike the previous outbreaks, where only under 15 kids were there, in this 2007 outbreak, few adult cases were also reported. And in this outbreak, particularly, the recovery periods and the neurological impairments were much longer, and the survived population ended up having very prolonged neurological side effects. I'm sorry. So if we revisit the clinical spectrum, as Dr. Ashish has already mentioned, it can range from a few asymptomatic cases to a florid acute encephalitis or an encephalopathy syndrome. So there would be a very high grade fever of a very short duration, followed by severe headaches, vomiting, some amount of abdominal pain, and some amount of diarrhea, which would be very similar to any acute gastroenteritis with high fever, which would be very similar to any other tropical illness during that season. This would rapidly progress to altered sensorium confusion-like state with seizures and with accelerating to comatose state and decerebrate posturing. The complications are the next subsequent step where complications such as electrolyte disbalance, hypoglycemia, rapid cardiovascular and respiratory compromise happen, after which there is gross brain edema. As Dr. Ashish mentioned, this gross brain edema, after many years, was evaluated to be found to be more of a spasm or a transient obstruction due to vasculitis rather than virus invasion, rather than actual thromboembolic. It was like a vasculitis phenomena causing severe brain edema, cerebral edema, and leading to various focal neurological deficits. Few patients even developed hemiparesis and severe motor and cognitive impairments, and few patients had hemorrhagic lesions in their brain. And subsequently, within 48 hours of hospitalizations, maximum deaths would occur. So if you look at this clinical spectrum, which runs through the various outbreaks of Chandipura virus, we can see that almost 100% of the patients had fever. Nearly 40 to 60% patients had vomiting, and nearly 90 to 100% patients had altered sensorium, convulsions. A few percentage also had diarrhea, which which uh, which makes the differential diagnosis even more difficult. So, high index of clinical suspicion, especially in an outbreak setting with an epidemiological link, is the main deciding factor when we can formulate our diagnosis or proceed for the virological tests, as Dr. Ashish mentioned. So, RT-PCR testing in blood and CSF is the gold standard. It has the highest sensitivity specificity. However, it is not it is not the common test that we usually do in our encephalitis tests. So when we often draw a CSF sample, we go in for usual CSF cell analysis, which would be fairly normal in these patients. The sugar proteins would also be minimally deranged. However, the encephalitis panels or the biofires or the multiplex PCRs that we are visibly available in the market, they do not have Chandipura virus. So unless and until we actually have a high index of suspicion, we might be missing the diagnosis. As Dr. Ashish mentioned, that we have high serology rates even in North India for this virus. We might have been not suspecting this particular virus, we might have been missing a lot of patients, and hence a sharp eye for these clinical symptoms is very important. Serological testing and virus isolation are few research-based testing that can be done and which must be done during an outbreak situation. Brain imaging, if we look at MRI or CT scans of all these patients who have succumbed to the illness or who have survived, there are no specific changes which can differentiate from the other acute encephalitis syndromes. There would be gross cerebral edema, there would be features suggestive of some amount of hemorrhagic lesions. There might be some diffuse non-specific vasculitic lesions. However, there would not be any specific points for clinching the diagnosis. How do we manage such cases? If the patients are able to timely reach a hospital, the best that we can provide is supportive care. So high dose of antipyretics, anti-edema measures, anti-epileptics, and fluid and electrolyte managements are the cornerstone of treatment, as no antivirals have been specifically researched, specifically found to be active against Chandipura virus. have airway protection in view of respiratory distress, and complications such as hyponatremia and cardiovascular compromise need to be aggressively managed. There have been schools of thought who have tried corticosteroids, low dose as well as high dose, to combat cerebral edema along with mannitol, and in case of raised ICP, but these are only supportive care measures. Antiepileptics to the tune of almost 3 to 4 antiepileptics have been used in multiple kids, as the seizures would be patients would be in status epilepticus. I'm sorry. Ribavirin is one of the antivirals which have been tried. There are no clinical trials as of now to support the use of ribavirin, but being a pan antiviral against the RNA viruses, it is postulated to be effective against Chandipura virus also. It inhibits viral replication and its role has been tried. However, the efficacy has not been established due to high mortality rates. Interferon alpha, having its high antiviral and immunomodulatory properties, have also been tried. However, there is no evidence or any clinical trial to support its use. Favipiravir has already been mentioned. This is one of the nucleoside analogs. It has been previously tried for Lassa and Ebola virus. It has even been used for COVID virus. It targets the viral dependent RNA polymerase. It has been postulated to cause little mutagenesis, for which it was severely discouraged for COVID. However, preclinical trials in mice have been found to be effective against Chandipura virus. As the virus accelerates and causes cytopathic effect in the brain within 1 to 4 hours, the favipiravir, being a RNA polymerase inhibitor, is able to catch up to the high speed of the viral efficacy. So this is one of the most promising antivirals as of now. Other than that, nucleoside analogs, monoclonal antibodies, and siRNAs are under research. However, none have fared well. Prevention is the cornerstone to combat the outbreak. Vector control, including insecticides, cleaning the environment, cleaning the crevices where the sandfly resides, is absolutely crucial. Awareness and surveillance have to be done, and early response at a community level is excessively important. Vaccine development has been a challenge because of the sporadic outbreaks that this virus has been having. However, no such vaccine has yet been formulated, which is showing any promising results. So, to summarize, this disease is very high fatality and very rapidly progressing disease. This highlights that we all need to have high index of suspicion, formulate methods where, if our suspicion is there, effective early detection strategies and a nearby center where we can actually send samples should be there. There are no antivirals as of now, so we all must put together to formulate strategies for research and clinical trials so that we can evaluate the safety and efficacy of these, and vaccine development is the way to go about it. That will all be from my side. I have not seen any patient with Chandipura virus, and I would be really eager to hear Dr. Raju's experience in this current outbreak, and also if we have been missing it and how we can be prepared for this outbreak if it hits north of India. Thank you so much.
Thank you. Thank you, Anivita. May I request the office to please upgrade Dr. Kameshwar? He is amongst the attendees, but he's not in the faculty. So please upgrade the Dr. Kameshwar. Sushil, are you there? Dr. Lalan, can you request the host to upgrade Dr. Kameshwar?
ठीक है सर, मैं बोलता हूँ उसको करने के लिए.
Thank you very much. I think we'll proceed ahead, and I now request Dr. Raju Shah, an eminent pediatrician from Gujarat, Ahmedabad, and as I said, that he's been the president of the Indian Academy of Pediatrics, to start his talk. And when we come to the discussion, then Dr. Kameshwar will take over.
Good evening, everyone. I am really thankful to the IAP Delhi as well as the Gangaram Hospital for giving me this opportunity to discuss something about Chandipura virus outbreak. We all know that Chandipura virus was first identified and coined the word Chandipura in somewhere in 1965-67. It is known to cause sporadic cases and outbreaks in western, central, and southern parts of the country, especially during the monsoon season. As already informed to us that the main vector is sandflies and ticks also. So only measures at present to control the disease is the vector control, hygiene, and awareness. It is peculiarly this disease affects children below 15 years. And the reason explained is that probably this virus is infecting people, though cases identified as sporadic or few outbreaks, but it must be probably like a flu illness or some other non-specific illness. It must be infecting many people in that area and they develop immunity. And because of that, when they are more than 15 years, they have developed immunity and not getting the disease. And some studies in southern Maharashtra, after such epidemic, looking at the immunoglobulin levels, they have found that the immunoglobulin levels are very high in the community, just informing us that probably it is because of the subclinical infection or probably non-clinical infection, they are getting the immunity. Gujarat actually first outbreaks was reported in 2003 and 2004, which was a small outbreak in a way that it was only 30 or 40 cases. Second outbreak was in 2014 when the outbreak was little bigger than what it was in 3 and 4. That was around 50 to 60 cases were there. In my institute, I have treated 4 cases. Actually, they presented and came from that Himmatnagar area only. It was, I think, in around 2010, I had got all these 4 cases in a short time of only 10 days. And all presentations were almost same. I contacted NIV Pune and sent the SIRA and CSF. And from there, they identified as 2 patients as Chandipura virus. We could survive 2 patients, but we lost 2 patients at that time. These all 4 patients had very high SGPT to the tune around 2000, 3000 at that time. And we tried to rule out all hepatotropic viruses and other viruses. When we couldn't trace to any virus, then we sent it to NIV Pune, and these cases were diagnosed as having Chandipura virus. This is for this time that when the cases were rising high, the health team went to all the areas and tried to look at what are the reasons and why it is spreading so fast in this area. And on 29th, the state had recorded 118 cases, 3 more deaths, take toll to 41 at that time. This continued to spread to many other districts after that. And unfortunately, the mortality is high because of the infrastructure is not that great. Almost all these children are treated at district hospitals where they have limited resources and facilities. And that may be one of the cause for high fatality rate. Unfortunately, there are no laboratory help which can detect the Chandipura virus in Gujarat till before about 10 days or so. Then they have established one lab and they are only accepting those who are having acute encephalitis syndrome, not other type of children tested there. So probably that is one of the reason why the subclinical or other type of infections are not picked up. Only those who are having AES are picked up. So total cases now are 148 like AES cases, which includes 140 from Gujarat, out of which 59 cases have expired. And in 51 cases, the Chandipura virus has been confirmed. Fortunately, last 5 days or so, there is a decline trend of the daily reported new cases. As you know, informed and just now presented by both the speakers, the presentation is normally with a high-grade fever, vomiting, lethargy. Many children get headache, pain in abdomen, body ache, and loose motions. Then they progress to drowsiness and altered sensorium, as well as there is a kidney involvement, oliguria also. In a routine test, there is a slight high count with lymphocytosis. Almost 40% of the children have high liver enzymes also, and few of them as high as 3 to 4,000. And some of the kids progress to encephalitis and coma within 48 hours or so. And in those children, the mortality is very high, as has been shown about close to 50 to 60% of deaths in these type of children. Management is usually like any AES syndrome. In Gujarat, the IMA, under the leadership of IMA and IAP, we have produced a document giving the management guidelines. Majority patients needs ICU management. As has been discussed, the management is like that of any acute encephalitis syndrome. No specific viral drugs are available. So most important part in the management is to reduce intracranial pressure, take care of seizures by using, if needed, 3-4 drugs. Most of these children needs ventilatory care, fluid management, and management of shock and hypoglycemia. Some of them, there is involvement of respiratory and circulatory system as well as liver. So we have to give supportive care for those children for that systemic problem. Recently, National Joint Outbreak Response Team was deployed in Gujarat to assist in undertaking public health measures and for conducting a detailed epidemiological investigations. These cases have been reported from Gujarat children under 15 years. As on 31st July, total cases reported were 148. They were from 140 from Gujarat, having from 24 districts. So it has now spread to many more districts. To begin with, it was only 3 districts. There are also cases from Madhya Pradesh, Rajasthan, and Maharashtra. And out of these 140 cases, 88 cases, 49 cases have expired. Until now, the Chandipura virus have been confirmed in 51 cases. So this is what the situation, in spite of some of these patients are treated directly into the ICUs with whatever facilities are available, still mortality is very high. That is what I would like to present, and if there are any questions, it will be my pleasure to answer them. Thank you.
So I'd like to welcome Dr. Kameshwar as a chairperson. He was listening to the talks as an audience, but now we have upgraded him to the chairperson. Couldn't join the link, faculty link. Sir, one question which I want to know is, what is the status of the morbidity in these patients, long-term morbidity in these patients? I know it is too early to say about this, but what is the record of these patients? Does it have the same kind of a morbidity as Japanese encephalitis has?
No, fortunately, the children, those who get fairly good recovery, there is not that bad sequelae. So as you know, suggested by Dr. Ashish, probably this is a vascular type of pathology. So the recovery is fairly good, or they die. So the sequelae is much, much less as compared to what we see in Japanese encephalitis and other type of the encephalitis syndrome. The first case that I had seen, the presentation was more or less like a Japanese encephalitis only. And we had suspected that and sent that samples to NIV. And to our surprise, it turned out to be this Chandipura. So presentation is more or less same, but the outcome is different.
Okay, thank you. Dr. Kamesha, are you there?
Yes, yes. Thank you so much
Sir.
for the opportunity and the privilege given to me. Dr. Raju sir, can I have one query from you?
Sure. Go ahead, sir.
Is it required to do the necessary investigations in all cases of acute encephalitis syndrome, thinking that we have to rule out Chandipura virus?
If the patient is coming from a rural area or they have traveled to rural area, then it would
Yes,
be
sir.
definitely useful, because the as we all know that the vector is a sandfly, which is usually not found in a urban setting. Most of our cases are also from rural area. There was not a single case from any urban area or city. So if you test all acute encephalitis, then you are not going to get good outcome. But those who are coming from rural area, those who have kacha house, those who are having their cattle house along with that, in any child or anybody coming in, especially less than 15 years, you may test them. That would give you a good result or outcome from that.
And I have another question from Ashish Chowdhury. See, our institute is having these viral laboratories, that referral center for viral diseases.
Yes, sir.
This usual viral laboratory, will they be able to do the test or identification and isolation of this Chandipura virus?
So, as per the CDC, this virus is graded as a biosafety level 3 agent, and this is basically for culture.
Okay.
But I think the way we did for COVID is also a highly infectious pathogen, and there is a respiratory aerosol and respiratory route as a possibility for transmission. Now, this is a vector-borne disease. I think PCR can be done in a BSL-2 plus laboratory, shouldn't be a problem.
Okay.
But
We
yes,
are
even
having that
serology for
laboratory
that
in our
matter. But I think I'll once confirm with NIV Pune exactly on how we should go about it, because we have no experience with this virus in our part of this country. But I think it should be a PCR can be done in a BSL-2, shouldn't be a problem. But yes, for culture, it's better to do it in a BSL-3 as per CDC guidelines. But the infectivity of this virus, uh, because it's vector borne. But then in culture, you have high titer of virus which will be generated. So I think BSL-3 would be better, but I would again take advice from NIV again and get back to you, sir. Yeah, thank you.
Thank you.
Unfortunately, the NIV is, or probably government is not allowing any other laboratory to test. So only NIV Pune, and now in Gandhinagar they have started one lab where they are collecting samples and doing this both test PCR as well as the ELISA. And so
Okay, sir.
if the
Yes.
government and NIV Pune gives some technical help, probably it can be better and it can be done
Yes,
easily.
sir. So
Both
in
are
that regard,
available
yes, sir. So
in
in that
NIV
regard,
Pune.
today I had talked to Dr. Vijay Bondre personally on phone, and what he told me is that the paper, they'll be sharing the primers and probes, the paper which they used for synthesizing the primers and probes, and they have told us to go ahead and synthesize the primers and probes and go ahead with testing. So only thing we need is a positive control from them so that we can standardize the real-time PCR, which we will do subsequently once we get the positive control. Then we'll be doing it here also, but then it will take some time to synthesize the primers and probes and get the control, and then to sanitize the virus in AIMS Delhi. Once we do that, we can go ahead and test. But yes, that's a good question which was asked earlier, that when to suspect, because should we be doing this as part of the encephalitis meningitis
Routine
panel?
investigation of AEH.
Yeah, because every patient we don't need not suspect and do, but yes, as sir pointed out earlier, those who come from rural areas, especially, and the clinical history matching AES, there we have a better chance of picking up Chandipura. Thank you.
So can I request, can I request Dr. Kamesha to take the questions in the Q&A of the audience, and put it to the experts. Now, Kamesha, please take the questions in the Q&A, sir.
Can I also ask one question, please? Dr. Shah, sir, I had a question for you. So we know that none of the current treatment options that are available are very specific against Chandipura virus. But in your experience, sir, what do you think steroids have worked? Do you think anti-edema measures have worked? Or amongst the surviving patients, with your experience, what do you think has been the best managing strategy for such patients?
Most important is to reduce the cerebral edema, and for that, mannitol and saline, they are considered to be the best. As there is no toxic edema over here, steroids has been tried, but it has not given that good results. But in all these patients, all the type of modality has been tried. So we don't know what is the best at present. At
Right.
the end, when we analyze all the patients, then only we will be able to tell that which modality would work better, whether only to reduce intracranial pressure with mannitol and saline, or steroid is better. So at present, it is difficult to comment on that.
And how
There is
those... Sorry.
sorry for interruption. There is one question from Parnit, and it is addressed to Ashish Chowdhury. The question is, what is the way to send sample?
I think
So the question is, what is the way to send sample from Parnit?
yes,
So
sir.
Ashish Chowdhury, you can take.
Yes, sir. I think because this is a highly infectious virus,
You have to send the samples of CSF as well as the blood, both. So because they are going to test in both ELISA as well as by PCR, and so we have to send samples of both. That should help. So you can separate the sera and send, and in a separate bottle you can send the CSF. Will help.
Dr. Ashish, could you please tell us how we will be sending the samples?
Yeah, so
and
CSF,
protect ourselves also.
Yes, I think it's best to collect the samples and send them in a triple layered packaging the way we're doing for COVID. That's the best and the safest strategy. And it ensures that the sample doesn't leak and doesn't infect anyone from the site of collection to the lab. So triple layered packaging as for COVID is the standard, I think.
Okay, thanks, George. After COVID, it must be easier for us to send samples also, because we have enough experience of the COVID.
Yes, sir. Definitely.
Dr.
Thank you.
Kamesha, could you please take up the rest of the questions in the Q&A box?
Sir, there was the only one question present, and there is another question from Sangita, that's from Kalyan, Brazil, attending meet from Philadelphia. So I can translate the abstract of today's meet in Marathi so that people from Maharashtra will be benefited. So it is nice to hear from Sangeeta that she wants to translate in Marathi and spread the abstract as well as the message to the people of Maharashtra. That is a great thing, and I think if permitted, we can give the chance to translate material in Marathi and this create awareness among the people so that any acute encephalitis syndrome like headache, vomiting, unconscious, coma, then lose stool under 15 years of age from these rural areas, so they can be aware of the Chandipura virus disease. Thank you.
If there's nothing else, may I request Dr. Lalan Bharti to thank all the participants and the speakers? Dr. Lalan, are you still there? Oh, he seems to have left. Well, I think the task of thanking everybody falls on me.
No, sir,
Dr.
I
Alok
can do
Bhandari
that.
is there.
I can do that, sir. I can do
Alok
that.
Bhandari is there. I just saw that.
I was there for a long time, but I couldn't. There was an error in that upgradation to the panelist link. I was very much in the audience link. It was a very useful and an informative thing, but and Chandipura virus is going to stick on, and maybe some variants will be there. Very good insight and very thorough work done by our speakers, and Dr. Raju Shah and Dr. Kamashar really guided the discussion very well. And I'm thankful on behalf of IAP Delhi to all the distinguished participants and delegates all across India who took out time and must have been gained immensely through this effort. Thank you, sir. Thank you, please. Okay.
Thank you very much,
Once
sir.
again, very much thanks you to the organizers, particularly Dr. Anupam Sasdev and President IAP Delhi, Dr. Alok Bhandari and the Professor Dr. Mukesh Dhankar, Secretary IAP, and also the staffs of the Sar Gangaram Hospital, New Delhi, for giving me the chance to join and share this session. Thank you so much.
Thank you very much,
good,
sir.
Thank
Okay.
you
Good
very
night,
much.
everybody. Thank you very much, Dr. Ashish.
Welcome,
The
sir.
rest I won't thank too much because they're our own people. You are the one who's from another branch. Great
Sure.
thanks to you. Thank you very much, Dr. Raju Shah, and thank you, Anivita, the
Thank you so much,
brightest
sir, for
star.
here.
Yeah. And good night, everybody, sir.
Good